Welcome to this explainer. All right, let's jump straight in. We're unpacking the absolute definitive blueprint for engineering a modern long-term care EHR platform, specifically tailored for the rigorous demands of 2026. If you're a founder, CTO, or health tech leader, you already know the landscape is completely shifting under our feet. So we're going to outline exactly how to build a system from the ground up that actually solves the daily operational chaos of long-term care facilities.
Okay, here's our roadmap for today. We'll be looking at the 2026 LTC landscape, diving into microservices and security architecture, mapping out core clinical and workforce modules, tackling interoperability and TFCA integration, dealing with Cures Act compliance mandates, and finally, engineering AI-native workflows. Let's get to it.
Section 1. The 2026 LTC landscape. So, what does a 2026 long-term care EHR actually look like on the floor? Well, spoiler alert, it is absolutely not a hospital system. Hospitals log discrete events, right? But long-term care? It's all about recurring assessments, constantly shifting census numbers, and honestly, a whole lot of incredibly complex billing logic. If a floor manager has to log into 3 completely different systems just to figure out who's on shift and what's due, well, your software isn't actually helping them. It's practically a hazard.
Think about minimum data set or MDS assessments. They are heavily regulated and incredibly time-sensitive. Just picture a typical Monday morning. A nurse swaps a shift, which immediately impacts floor coverage, which then delays a critical assessment which, you guessed it, eventually tanks your billing margin. Fragmented patchwork systems simply cannot carry that kind of load. They just lead to missed handoffs and absolute nightmares with manual data entry.
To put this into perspective, we're talking about a market projected to top $10.3 billion by 2030. Building a solution here requires a fundamental shift in mindset. Facility operators do not want just another feature catalog. They desperately need a unified workflow spine. We want clinical teams spending less time reconciling endless spreadsheets and way more time actually caring for residents.
Section 2. Microservices and security architecture.
Now, the contrast between the old way and the new way is pretty stark. Those old, rigid, monolithic EHRs, they're a massive liability now. I mean, pushing an update to a billing code should never, ever risk taking down your entire clinical documentation system. So, in 2026, a microservices architecture is absolutely mandatory. Your specialized domains have to operate independently. The patient service handles demographics, billing owns the charge capture, and so on. And crucially, each service owns its own isolated data, which means protected health information, or PHI, doesn't dangerously leak across shared databases.
Of course, microservices do add a layer of compliance complexity. To align with the NIST cybersecurity framework, you really have to layer up your defenses. Every single internal channel needs strong encryption, like mutual TLS, because your internal traffic is honestly just as vulnerable as external traffic. You've got to adopt strict zero-trust principles at the service level and back that up with continuous SIM monitoring. Oh, and for those dreaded HIPAA audits, distributed tracing using correlation IDs is totally non-negotiable. You need to track exactly who touched what patient data and exactly when they did it.
Section 3. Core, Clinical and Workforce Modules.
This perfectly maps out the essential operational synergy your platform has to have. Just think about your primary users for a second. You've got directors of nursing, MDS coordinators, and the billing teams. If your clinical assessments and your workforce scheduling aren't talking to each other seamlessly, you are literally building a bottleneck into the system. Connecting these native modules means cleaner claim flows, far fewer denials, and a whole lot less manual coverage chasing for your DON.
Section 4. Interoperability and TFCA integration.
Right, moving on to interoperability. In 2026, TEFCA is absolutely no longer optional. Under the Trusted Exchange Framework and Common Agreement, you sign one single agreement. You implement one set of APIs through a Qualified Health Information Network, or QHIN, and boom, you instantly connect your platform to thousands of organizations. This completely kills off those painful, bespoke, point-to-point integrations that used to drag on for months. It is essentially the interstate highway system for health data exchange in the US.
But to actually play in this ecosystem, your engineering team has got to build FHR native APIs from day one. Trying to retrofit FHR onto some proprietary data model later on, it's incredibly expensive and highly error-prone. You specifically must support FHR Release 4, conform to the US Core Implementation Guide, and fully support US CDI version 3. Plus, you'll need bulk FHR for those big population queries and UDAP to establish organizational trust. These aren't just industry buzzwords, folks. They are the strict, non-negotiable protocols you need to actually pass certification.
Section 5. Cures Act Compliance Mandates.
This leads us right into the Cures Act. You have got to actively avoid any technical or business practices that artificially delay data access, period. Information blocking rules now apply to all electronic health information, not just a small subset. Listen to this. If your software limits or delays patient access, you could be facing civil monetary penalties of up to $1 million per violation. $1 million. Yes, there are 8 strict exceptions like preventing harm or ensuring security, but trust me, every single one requires incredibly rigorous documentation.
And these regulatory deadlines, they are approaching fast. Supporting US CDI v3 and payer-to-payer exchange are massive milestones, sure, but the real cliff edge you need to watch is October 2026. That's when CMS is cutting off the legacy IKEA's front-end interface for manual MDS assessments. If your platform doesn't automatically format and submit these by that exact cutoff, it's virtually useless to a facility operator. In this specific space, compliance isn't just a nice-to-have feature, it is literally the cost of entry.
Section 6. Engineering AI-native workflows.
Okay, let's talk about AI. It's incredibly critical to understand the distinction here. A 2026 EHR cannot just be AI-enabled. It must be AI-native. Bolted on AI, that just forces clinicians to do all the heavy lifting in isolated, clunky dashboards. No thanks. An AI-native system leverages a cloud-native architecture where ambient listening is the primary, totally frictionless way data is captured. AI literally shapes the data model from the ground up. We're talking about generating notes, suggesting billing codes, and routing workflows, all without the constant manual clipping.
Let's actually look at an agentic workflow in action. Picture this. Before a visit even starts, an AI agent uses Retrieval Augmented Generation, or RAG, to pull live patient records directly from the EHR, which ensures zero hallucinations. Then, during the encounter, ambient listening drafts perfectly structured clinical notes in the background. Post-visit, another AI agent automatically auto-codes and submits the final claim. But, and this is a big but, strict clinician-in-the-loop guardrails are mandatory here. The AI recommends, but the human clinician always has the final approval.
As we wrap up this explainer, you really need to sit down and ask your engineering teams a hard question. Are you building a unified, intelligent architecture for the future? Or are you honestly just putting a fresh coat of paint on a fragmented, legacy tool? By fully embracing microservices, strictly adhering to FHIR standards, and engineering AI directly into the core from day one, you have the very real chance to actually cure the administrative chaos of long-term care. The blueprint is right here. The only question is, are you ready to build it? Thanks so much for joining me.